Okay, welcome to our third RadPath lecture, Getting an Adequate Specimen. My name is Matthew Hartman from Pittsburgh, PA, part of AMSR. As always, these lectures can be found on the ACR Building Blocks site. Again, our Anki deck is available. For instructions, go to the About section on our YouTube channel. This is based on a RSNA presentation from several years ago where we had one of our RadPathers, Gene, who is now a resident with us. This will be an overview of this presentation. Again, if you want to see the whole thing, go back and forth. I encourage you to check out the Building Blocks site and look at the entire presentation. What we'll be talking about is getting an adequate specimen. This involves working with the pathologist very closely and making sure we have an adequate specimen. So when the final diagnosis is made by the pathologist, we do not get inadequate tissue available. We want to do this once, get a good sample, and let the pathology make the final diagnosis. We'll start with renal biopsies. These are usually non-targeted. This is an example from an ultrasound-guided biopsy where our needle goes in, we get the sample, and what the pathologist is looking for is 10 to 15 glomeruli, which they will look under the dissecting microscope, see these small red circles, those are the glomeruli, as opposed to, and these are found in the cortex, as opposed to the medullary rays, which are from the medullary portion. So when we go back, we are aiming for the cortex here. And these biopsies can be performed either under ultrasound, which is how I like to do them, or via CT, which is sometimes easier if you have an obese patient and need to get through a lot of fat, remembering that fat is our enemy with ultrasound and makes the imaging challenging. Thyroid biopsies. Thyroid nodules are very common, and we are often asked to biopsy these. Do we biopsy all of them? No. We use the TI-RADS classification, very similar to the BI-RADS for breast, to decide which ones we're going to biopsy based on level of suspicion and size. Here's a thyroid nodule. You can see this got a TR5, highly suspicious. This is something we would want to biopsy. Pathologists, when they get the sample, will be using the Bethesda system for reporting thyroid cytopathology. This is what we will see under the microscope after we take our sample. Again, we'll be looking with a pathologist, and what we want to see are 6 groups of cells. If we don't get 6, sometimes all you get is blood or colloid, and you will get an insufficient sample. You could keep biopsying 100 times, and I'm telling you, some of these thyroid nodules are just very stingy, and you'll never get a adequate sample. And that can be very, very frustrating, but fortunately, those are the minority of the cases, in which case you're going to follow up the nodules or do a rebiopsy. Here is an example of ultrasound-guided biopsy, our needle going in. We avoid the vessels and hopefully get a diagnostic sample. Liver biopsies, these can be targeted or non-targeted. By non-targeted, these are usually cirrhotic patients or a transplant, no focal lesion. They just need to know what's going on with the architecture inside the liver. And we will get the pathologist hopefully a nice core sample that they can look under the microscope with. For some challenging patients, especially those immunosuppressed, low platelets, they can sometimes do these biopsies through a transdrugular approach. But in the end, we end up with a nice core, and the pathologist can make the diagnosis. On the other hand, we have targeted organ biopsies. Here we have a focal liver lesion. We identify it under ultrasound and take our sample. You notice the beating heart right behind it. So I love doing these under ultrasound. You see exactly where your needle's going. Again, tissue's the issue, and this ended up being metastatic small cell carcinoma. Another very interesting case, this patient had a lung nodule, had endometrial thickening, known carcinoma, and the question was, is this metastatic or not? That's going to change everything. Take the sample. We're, of course, going to use CT for these biopsies, and it ended up being carcinoid, completely changing the patient's care. Breast biopsies. Hopefully everyone gets a day in breast. Some great rad path opportunities there. And biopsies are often performed either with ultrasound or MRI, lining it up with the grid. FNAs really do not have much of a role for mammographic imaging. The good news, they're usually getting a core and they're going to get a great sample. Lymph node biopsies. So this can be performed either as a core or with the FNA, and we'll talk about why you might want to do one or the other, or usually in those cases, both. So if we get a core, get that nice little section, they can embed it in the paraffin, slice it down, and they really get a nice sense of the architecture for that lymph node. As opposed to doing an FNA, where they will get small samples, put in liquid, and do something called a cell block. The pathologists will use both of these methods to make the final diagnosis for the lymph node. Again, trying to say, is this a lymphoma? Is it metastasis? Or is this just reactive? This was one of our first cases from tumor board, if you remember, the FDG avid lymph node, do our biopsy, and this was a case of lymphoma. So take-home points. Patient safety, of course, is the most important thing, but after that, getting an adequate specimen is the most important thing for the biopsy. We want to be one and done. We don't want to have the patient come back. Sometimes, despite our best efforts, we will get an insufficient sample. The choices are to rebiopsy it, follow it, and sometimes, especially for lymph nodes in the axilla or inguinal region, the surgeon will actually go in and take the whole lymph node out. We try to biopsy the viable part of the organ or pathology so we can get viable tissue and not necrosis. Working with the pathologist on site, looking under the microscope with our sample. Do we have a good sample or do we not have a good sample? That is probably the most important thing to getting an adequate specimen, working with your pathologist. Thank you very much.